Hello, everyone. This is Braswell Dean with the Providence Hospital Department of Family Medicine, and this is Codeology, a medical coding review. This is a review of sometimes a complicated subject or a mysterious subject, medical coding, and it's our attempt to bring in the complex world of coding into the ology world of doctors, the studying world of doctors. So we're trying to write a course in your language, something that you could relate to, and I hope you enjoy it, and I hope it helps you. It's intended for our Providence Department of Family Medicine residents or medical students joining us, and or our faculty members as well, or anyone else who would like to have a review. So we hope this helps you, and the intent is to review medical coding so that you can ensure your medical coding and documentation is as ethical as possible. And we want to do it in a nice, enjoyable way. So over the years, since around 2003, so many doctors I have worked with that basically have all the same emotions. They're confused. They feel like they can't learn proper coding. They feel like there are just too many rules. There is a fear of overcoding. You don't know what to put. There's really no time to learn coding. It's not taught very well in medical school or taught very well in residency. They feel like they don't have much access to help, to review charts or things like that. Many are just, quite frankly, embarrassed to ask. And maybe they're senior partners, but they just feel like this is the way we've always coded, and we've had residents go to join different practices, and they've basically told the new resident, well, this is the way we've always coded, and this is the way we're going to code, because no one really knows the rules. It's not written in my language. Some people say, I'm just not going to do it. I give up. So many doctors just hate this topic. And compounding on that is the fact that even if you kind of know how to code, sometimes you're just really uncertain about what requirements need to be in your note. Whether you handwrite your note like in the old days, or whether you're using a fancy EMR system these days, sometimes you feel like you're at the mercy of the EMR because it's just putting a lot of things in your note and you're not sure what's required or not. So we're going to go into that and make sure you understand it. So as a result of not understanding how to code and not really understanding what you have to write down, a lot of doctors, they simply just undercode or maybe over document because they really don't know what to do. So before we get into the course, I just wanted to give, as always, attribution and acknowledgement to a couple of the coders here at Providence who back in 2003, took us about a year from 2002 to 2003, but Denise Blackburn and Kelly Adamite Evans were so helpful in the development of this course. It could not have been done without them. And so always want to acknowledge that this was a work not just from the doctor's point of view, but from the coder's point of view as well. And just to say, this little course has been given around since about 2002 here at Providence Family Medicine, but also around the state, not only to doctors groups, hospital groups, but to medical billers association groups, and also at a statewide conference in Florida. So it's been around, and a lot of people have heard it, and I hope as you hear it, it helps you as well. Our course objectives. So to start off with, we start with an acknowledgement that we're not trying to turn anyone into a professional coder. If there are other questions, please consult your professional coders. But what we are trying to do is get you comfortable. And get you comfortable so that you can get up and running and feel good about the coding that you do, for the services that you provide, and understand that, again, everything that we're going to be teaching you is from the viewpoint of trying to make your coding as ethical as possible. And we're going to acknowledge that the code has 3 parts, and 2 of those 3 parts you guys are already pros at. You know history and physical probably really well. You guys are history and physical machines. But we're going to teach you one more part, one more skill, and that is the complexity of medical decision making. And if we can teach you that, we have given you a new yardstick by which to measure your practice and measure the medical services that you render. So you'll hear me reference, and you'll hear people reference, complexity of medical decision making, as also known as just medical decision making, also known as CMDM, also known as MDM. And I think basically folks try to abbreviate it so they don't have to say complexity of medical decision making over and over and over. So you'll hear me call it MDM a lot, just because it's easier to say. But MDM, again, equals complexity of medical decision making, which is the big, powerful message that we want you to get out of this course. And we want you to learn to derive the MDM, the complexity of medical decision making, first, and let that big golden yardstick drive the decision, your decision, as to what code you will select to render for the services that you provide. And when you learn to let the MDM drive the code, then you're free. You can ask all the questions you want in the history and the physical and not worry. You can do all the great physical exam elements without the worry that that is impacting your MDM. So we want to always let the MDM drive the code. And if you're one of our residents and you have one of the worksheets in front of you, use it, because it'll be very helpful for you. The entire course and all of the patient cases and patient examples that we give is based off of this worksheet. And so that's something handy for you. And if you don't have it, you can see, you'll just go through it, and we'll be glad to provide you a worksheet if you give us a call. I'll be glad to help you out. But the main thing I would tell you is that doctors who follow the rules of medical decision making and follow the rules that are provided for documentation have much stronger notes when folks review those notes, because auditors will tell you and reviewers will tell you that notes that are following the rules of MDM are much more compliant and also stronger notes. They're better documentation than notes that don't. And also, following the rules of MDM will increase your compliance with Medicare's rules of documentation, and also, again, you'll tend to increase your productivity, because you will probably not be one of these doctors that just down codes because you don't know the rules about medical coding. So here are a couple of lessons from medical economics from 2009, just to set some of the examples here. A physician in one practice ignored the advice of coding personnel who raised concerns about erroneous E&M service levels, and the consultant found that the practice was losing X amount of dollars this way. And as it turned out, the EMR system was undercoding. So this was an example of the doctor sort of trusting in the EMR system, thinking that the EMR system would handle everything. But again, the EMRs are not infallible, and many times they undercode for services and many times they overcode for services. So the number here is not so much important as the principle here that we're trying to make, that if you trust in the EMR systems, that doesn't necessarily turn out to be accurate. Another costly lesson, number 2, is it was a really well-liked physician, and he didn't really understand what he was doing, and he was losing X amount of dollars. His staff tried to protect him for it, but not after he was forced to sell his practice because he just didn't do a very good job. And so again, the physician seemed happy, but no changes were made. And again, I think in these days, especially with physicians who are working in private practice, every little bit helps, and you're trying to make ethical decisions. But again, it could be the difference in your practice being able to be sustainable or not. So again, these are lessons that we hope you learn for the success of your practice. Lesson number 3, here's an example. Oh no, a physician regularly lost his temper with his coding staff for their billing practices, and he intimidated them, so they basically always billed as he demanded. Because he didn't understand the coding rules, he routinely underbilled in some areas and put himself in violation of medical necessity in other areas. And basically, he didn't make X amount of his bonus that year. So again, not so much the amount, but the principle is that he was in violation of medical necessity. And again, if someone reviews him, it's just a way of really proving that documentation is not correct. And it puts the practice in compliance problems. So not so much it could be an individual problem, but it could be a system-wide problem if you are a big employer of a lot of physicians and their charts are not meeting medical necessity when reviewed. That's a bigger compliance issue. So you want to make sure your healthcare system is in compliance with these things. So we'll get into some of these lessons as well. So let's talk about the basics of coding. And again, this is the intention here, is that we are going to write this in language that the doctors can understand. Now, we know that you guys are very familiar with the history and the physical. So you guys already know that, but what we're going to concentrate on is something you may not know. And this is sort of the last third of the puzzle here. That's the complexity of medical decision-making. Now, complexity of medical decision-making is really itself made up of 3 other things. So if you're one of these people, and I've been told by some of these people that coding is so ambiguous, there is no way anybody in their right mind could learn coding. And so this is a slide to address that person. And this slide shows you that coding is not ambiguous. The history and the physical may be stuff you know a lot about, but risk, data, and diagnostic management rules are very easy, but also very specific. And so if you don't know CMDM, if you don't know complexity of medical decision-making with its 3 parts, you're missing out on a lot of important information, and we're going to give it to you. So no, coding is not ambiguous. So let's take a few fast facts and to introduce some terms that not everybody may know. The first thing is to realize that E&M, which is what this course is about, Evaluation and Management Codes, this is what this is. These are the codes that we're talking about, and they're the codes to report your professional services. In other words, for example, when somebody comes in and says, you know what, doc, I have a sore throat. You say, okay, well, maybe that's the chief complaint. So you ask a history of present illness, review of systems, you go over past medical surgical history, medicines, allergies, you do a little family social history information, which is all the historical component of this, and then you do some objective stuff. You look at the vital signs, head, eyes, ears, nose, and throat, heart, lungs, abdomen possibly, or other organ systems, and then you come up with an assessment, and then you come up with a plan on what you're going to do with this person's sore throat. That's evaluation and management. Of course, the assessment and the plan, that's the management part. The evaluation is the history. So those are codes that you use to document those services. Now, if somebody's coming in for a physical exam or a well child check or like a Medicare wellness visit, those are prevention codes. Now, those preventative medicine codes are not the same thing as the E&M codes. So what we are going through right now today are E&M codes. So whether you are a consultant, a surgeon, an internal medicine doctor, a GYN, a family medicine doctor, E&M coding is E&M coding is E&M coding. This is your bread and your butter. This is what people come to you to ask your opinion about. Now, if somebody comes in and says, you know what, I want a knee injection or a hip injection or some other procedure, then the doctor uses the CPT codes. So those are different than E&M codes, and those are also different than preventative medicine codes, CPT. And the codes that justify the use of the CPT codes and the codes that justify the use of these E&M codes are the diagnosis codes. And those codes are called ICD codes, International Classification of Disease codes. Now, when this course was written, we were using ICD-9 codes, and currently we are using ICD-10 codes. But that's what these are. So to use E&M codes, you'll justify it with an ICD-10 code. So in other words, the ICD-10 code might be hypertension, asthma, and diabetes. The E&M code might be a certain number. Or the CPT code might be used for a knee injection, but the ICD-10 code might be osteoarthritis of the right knee. So you can see that the ICD-10 codes are used, they're like the common denominators. They're used whether it's E&M coding or CPT coding or even preventative coding. They're used for all the different services. And let's say somebody comes in for evaluation of diabetes, hypertension, and COPD, but also wants a knee injection. Yeah, you can do both. You can do the E&M part to check on the diabetes, hypertension, and COPD, and you would use a 25 modifier at the same time when you're using the CPT code for the knee injection. And that 25 modifier tells the billers, the coders, the reviewers, that the same doctor is performing two separate services on the same patient in the same day. So to do two separate services, you have to use that 25 modifier. Now, who oversees all this stuff? This is the CMS, the Center for Medicare and Medicaid Services. There's two M's in this phrase. I always thought it should be CMMS, but there you go. It's CMS. And this agency is the agency that disperses the monetary compensation to the doctor for these different codes. It used to be called the Healthcare Finance Administration, but now it is CMS. Another really important concept, and we alluded to it in our last example, is something called, we were referring to medical necessity, but let's talk about the chief complaint first. The chief complaint, since you were in medical school, has always been taught to you as almost like what comes out of the patient's mouth. And they always, like when sometimes they teach it medical education like quotes. It's in quotes. The patient says, whatever the patient says is in quotes. You know, Granny comes in to see you and, quote, check my feet. Or, you know, check my hip. So that's the chief complaint. But a lot of times in the real world, Granny comes in and says, quote, check my feet, check my hip, but Granny's blood pressure is 200 over 110 in the real world. So what's the real world doctor going to do? You know, you feel like you're a little bit handicapped there. You don't know what to do. Is it wrong to say chief complaint is check my feet, check my hips, but then start addressing Granny's blood pressure? Because Granny didn't tell you to do that. She didn't ask for it. So a lot of doctors, they don't know what to do right off of there. But in the real world, it is very appropriate for you as the doctor to add to that chief complaint. So that chief complaint now is not only what the patient says, but also what you as the doctor thinks needs to be done at the time of the service. It can be the agreement, what the doctor and the patient think. It can be what the doctor thinks also. So now Granny comes in and says, check my feet, check my hip, but the doctor can also ethically put in there, check Granny's blood pressure. And maybe, since Granny's a diabetic, I'm going to check Granny's blood sugar. And maybe, because Granny has dementia and she doesn't even know what to ask for, maybe this is an appropriate rule after all. So yes, you as the doctor can add to the chief complaint. But when you do that, you got to make sure that whatever is in that chief complaint is reflected throughout your note, and that's called medical necessity. I cannot overemphasize how important this is. This is where it is so easy when you're reviewing a doctor's note to find problems, to find compliance problems with the note. In other words, in our example, when Granny comes in with check my feet, check my hip, and also we're going to check her blood pressure and her diabetes and dementia, all of that stuff needs to be in the chief complaint. So therefore, when somebody's reviewing your chart, you should have a little bit of stuff in the history of present illness about the hypertension. You know, is she compliant with her medicines? You need to have stuff in the review of systems. Chest pain, shortness of breath, something like that has to be related to what you're doing for the patient. Past medical surgical history, of course, that's easy, especially in the time of EMRs, because all that's there. You want to make sure you review it. Family social history, does Granny smoke, etc. So then in your objective section of the note, you're going to be noting her vital signs, and you're going to be doing your exam, and then you're going to be coming up with an assessment and a plan. And then obviously the plan is, the assessment is going to be hypertension poor control, maybe diabetes stable, dementia stable, and then the part about the feet and the hips, whatever your assessment is there, and then the plan is going to be what to do about all that. So that's an example of how medical necessity is seen starting from the chief complaint all the way through the note down to the assessment and the plan. If a note has that, it is said to have medical necessity and be in compliance with proper documentation. If it doesn't, it will be out of compliance. And you run the risk of having some type of penalty. Another thing that sometimes gets asked is, let's say Granny comes in with a past medical history of like 30 or 40 things. I mean, Granny's just got everything wrong with her. Even with a laundry list of a whole bunch of medical problems, you can select what you're going to be dealing with in the chief complaint. So perhaps Granny has rheumatoid arthritis, but you're not going to be checking that today. That doesn't have to be in the chief complaint. You know, let's say Granny has osteoporosis in his own osteoporotic medication, and you don't feel you have to check that today because you just talked about it on the phone or you just something. So you're not obligated to pull all of the past medical history into the chief complaint, but you should pull the items of the past medical history out of past medical history into the chief complaint if you feel like they need to be addressed at the time of the visit. So past medical history is a big, long, it's a big, long, comprehensive list, whereas the chief complaint is a sub-list of what you're actually going to be dealing with today. So I hope that clarifies the differences between the chief complaint, the list of things that you're going to be doing there, and how that's important to medical necessity, and then how that also is a little different than the assessment of a review of all of the past medical history also. You can do that, but it doesn't affect the actual service rendered. So this is how your note helps document your services have met this all-important concept of medical necessity. Now, let's talk about a couple of other small questions. A new patient. What is a new patient? Well, it's someone who's never been seen by your practice, or if it's been greater than 3 years since they've been seen. That's a new patient. Now, a question always arises is, well, okay, let's say my partner goes on vacation and I'm covering for my partner, and now I'm seeing their patient, and their patient technically is a new patient to me. Is that a new patient? And the answer is no, because the patient, although may be technically new to you, they're not new to the practice. And that's the fundamental issue there. So a new patient is someone new to the practice. They've never been seen by the practice, or it's been greater than 3 years since they've seen anyone in the practice. But if they're seeing a covering doctor, although that encounter is brand new to the covering doctor, the patient is not treated as a new patient. Okay, so also a couple of other pitfalls is the shortcut phrases, like, and if you'll kind of look down here, things like past medical, family, and social history sections. CMS advises you to avoid phrases like non-contributory or NA, like for non-applicable, because CMS usually does not consider this to be adequate documentation. So come up with some things that you can use to say things are looking good or not good or whatever, but if they're non-contributory, say something, but don't say non-contributory. Or when documenting your physical, avoid things like normal or negative, or WNL, mean, like within normal limits, because these are insufficient according to CMS, by CMS standards. So those are some other things that sometimes get, they're just commonly seen things when charts are reviewed that will be flags to doctors being in compliance. So let's begin to understand more of the basics. This was the first little slide that I made back in 2002 when I was getting ready to try to make this course. I wanted to start out as simply as possible. And so keeping in that simple mission, we'll say once again the code has 3 components, and to generate the code you need to be familiar with the 3 parts of the code, and that's what we're going to be looking at today. So this is a copy of our little worksheet, and so if you don't have this copy, maybe you could pause this and try to print the screen or something like that, so you'll at least have something to go by. But and if you do have a copy, this is basically what we're looking at. Again, I've put arrows here to represent the 3 parts of the code. And the 2 you already know. You know the history and the physical. And the one part that we're going to be emphasizing in this course is the MDM, the complexity of medical decision making. And if you know this, you will allow this little section here to drive what code. These are the E&M codes that you can select, whether they're a new patient or established patient, and these are the rules. So you don't have to worry about the questions you ask or the exam things that you do down here. Now you can just select your code for services based on ethics. And this is made up of these three parts: the risk, the data, the diagnostic management decisions. And these rules, I'm telling you, are so easy. We're going to emphasize the easiest rules to help you learn. And if you do this, if you learn these easy rules to generate the MDM, your coding will be really fast and ethical, and then your documentation is going to be really complete. Let me show you how. So we haven't even tried to learn these rules. Let's learn how to use the form before we learn how to learn the rules, okay? So I tried to make this little worksheet about as easy as possible so that even someone with a little as little understanding as I had could understand it. So again, if I can do it, you can do it. And basically, all we're looking at is, we'll just jump right in. If the risk is moderate and the data is only 1 and the diagnostic management is 3, then the two highest levels in common, which would be this level and this level, you just draw a little line over, and that's your code. It's a moderate complexity of medical decision making. And then whether the patient's new or established, in this case, our hypothetical person is established, you just draw a line over, and this is how you get a 99214. That's the E&M code for the visit. And the little d tells you that a detailed documentation is required in your note. So we haven't learned how to get these rules yet, but just to see how the form works, we need 2 levels in common to generate the code. So it's not just based on one thing. We have some balance here to generate this code. Now, you'll see some other abbreviations. The PF stands for problem-focused documentation, and the EPF stands for expanded problem-focused documentation. And we're going to show you what those are. Don't worry. And the C down here at the bottom stands for comprehensive comprehensive documentation. And all of this documentation is history documentation as well as physical documentation. So this little d again stands for detailed history and detailed physical documentation. So just remember, this 99214 hypothetical code that we just practiced generating with our little worksheet, it understands that if we are generating the complexity of medical decision making based on these rules, and we let this be our code rather than how many questions we ask the patient or how many exams or how many things that we do on our exam, we can rest assured that we're not overcharging anybody. And we can also rest assured from a practice standpoint, we're not undercharging. We're generating the appropriate code based on the medical decision-making rules. So we're doing appropriate level work, and we are doing ethical work. So documenting this nature justifies the level of your work. So even though we generate the complexity, we need to document it because that justifies the work. So not only have we come up with the 214, we are coming up with the battle plan on how to document that 214 so that it's ethically justified. So now let's look at the coding worksheet, and down here on that right-hand column. And this is the history section, and this is the physical exam section. So in our hypothetical patient here, a detailed documentation is required. So detailed documentation, we can see whether it's problem-focused or expanded problem-focused. That would be only 1 to 3 of these bullets. But detailed or comprehensive requires greater than or equal to 4 of these bullets. Okay, so location, quality, severity, duration, maybe of Uncle Joe's back pain. You kind of got that, the timing or the context of the back pain. You know, it only happens on rainy days or whatever. Modifying factors, whether it gets better or worse with rest or Tylenol, or associated signs and symptoms. Maybe it's associated with tingling in the leg or the right leg, things like that. So associated signs, symptoms, or modifying factors, that's always a couple of good bullets. But you think to yourself, well, I can do that for Uncle Joe and his back pain. But what about if Uncle Joe comes in with diabetes, hypertension, and COPD? Are you guys asking me to document the location, quality, severity, and duration of the COPD? That doesn't make any sense. And I would say so many doctors, they don't know what to do with the HPI when they have a lot of patients coming in with a whole bunch of medical problems. And isn't that really what goes on in primary care? You've got so many patients with chronic care management. So the answer is no. You don't have to talk about the location, quality, severity, duration, timing, context of Uncle Joe's diabetes or COPD or hypertension. But if Uncle Joe has 3 or more chronic medical conditions, there's a provision for you. And I put it right over here so that you can check off that the patient has 3 or more chronic medical conditions, and you can say if that disease is stable or non-stable, or suboptimally controlled or optimally controlled, or doing well or not doing well. That's all you got to do. That's the minimum. Now, of course, you can say more. You can put a little bit of the narrative in, like Uncle Joe hadn't been taking his medicines or ran out or can't afford it. You can put a lot of that stuff there. But the minimum requirements for compliance when your chart may be getting reviewed is to put 3 or more chronic conditions. Or if Uncle Joe's coming in for a bad back or something else, you can describe it. So I hope that helps, because this is sometimes one of the most confusing sections in documentation. So many doctors don't know that they can use the documentation, just a sentence that says the patient has 3 or more chronic medical conditions, A, B, and C, stable. Let's jump to ROS. Let's see what documentation requirements are required in our review of systems for a hypothetical patient with a detailed complexity of medical decision making. Well, to document that MDM, you have to have 2 to 9 bullets in the ROS. Really? Absolutely, really. So you would have to have maybe, oh, and we'll put a few of these in. Let's put these in now. Sorry, I didn't do that. But in this example, you could just say 3 chronic conditions. But now in this, you only need 2 bullets. So you could say no chest pain, shortness of breath. You could do that. Or you could put more. But just remember, the ROS, you can ask as many of these ROS as you want. You only need a minimum of 2 for detailed documentation of our hypothetical 99214. For past medical history, family, and social history, you only have to have 1. Now, just note that the EMR documents all 3 all the time, every time. Does that put you like, does that make you, it seem like you're over documenting for your services? No. As we've said before, your medical decision making is driving what the code is, not all these documentation bullets down here. Let's look at the physical exam. In our hypothetical example, a detailed documentation of the 99214 would require 6 organ systems, 2 bullets per system, or 12 bullets from 2 organ systems. But I think for most primary doctors, I think just getting in the habit of 6 organ systems, 2 bullets a system is really, really easy. Let's go through and see what that looks like, because this is another area that sometimes people have trouble with. First, constitutional, vital signs. Now, in the old days, when people used to write charts out by hand, they would write VSS, vital signs stable. But nope, can't do it. You're not supposed to write it out like that. You're supposed to write it out like what the blood pressure is, what the pulse is, the temperature, the weight, the respirations, whatever you're going to do, the vital signs. Now, your EMR nowadays is doing all that for you. That's great, super duper, but you got to acknowledge that the vital signs look okay, like you've reviewed them, and you also, the other bullet is you got to say something general about the patient. One of the things that I've used is euvolemic, euthyroid, non-toxic, but say something general. Have to have a general statement. That's a bullet. It's a constitutional bullet. You don't have to have it. You could pick another organ system. You could just talk about eyes and then add GI. That'll be 6. But I think generally it's easy to put something in general about the patient. So eyes, let's talk about eyes for a minute. Pupils equal, round, reactive to light, extraocular muscles are intact. Probably you've been doing that your whole career, right? You've been doing it for sure since you were a medical student. But you know what? That's only one bullet. It doesn't make sense. But to the world of the coders, that's only one bullet. So you as the doctor have to choose another bullet that you're always going to be doing over and over and over to sort of get in the habit that this documentation is reflecting what you do all the time. So one of the things is, the other easy one to me is conjunctiva. You could say pupils equal, round, reactive with light, extraocular muscles are intact, conjunctiva are clear. Boom, done. It doesn't make any sense to chase the optic discs if you're not going to be doing it every time. Like little Jimmy comes in with a sore throat. Hold still, little Jimmy, let me check your optic discs. That doesn't make a lot of sense. So always try to pick the easy stuff. If you do want to examine somebody's discs, go for it. Or if there are other things that you do as a part of this exam that aren't even on this, do it. Do the exam that you know to make you a good doctor, but you've just got to have a minimum of 2 bullets on this piece of paper. This is not my favorite exam. This is coming from CMS. This is what they look for. So I'm showing you how to make sure your documentation is rock stable, ethical. Let's look at ear, nose, and throat. Tympanic membranes, you could look in their ears. Pearly gray, you could say something to it. Or if you don't want to look in everybody's ears, nares, patent, oropharynx is, patent. You can say something like that. Or you can do all 3. Or you can do 4. But you got to have a minimum of 2. So if you're in that habit, pick what you do. Pick what you do. Neck, supple, full range of motion. That's good, but you got to have something else. Say no thyromegaly. Well, you know what? I do a lot more things on my neck exam. Do it. Put it in there. But you got to say no thyromegaly. You got to say something about the thyroid, even if you do a whole bunch of other stuff. But I examine the lymph nodes. Well, that's down in the lymph nodes section. But that doesn't make sense. Well, to the coders, if somebody's going to be reviewing your chart, put what they're looking for in the section that they're looking for it. Okay, let's go to cardiovascular. This is another one that causes trouble sometimes. When you were a medical student and a resident, you put regular rate and rhythm, no murmurs, gallops, or rubs. It sounds like a lot of information, doesn't it? But to the coder, that's only one bullet. That's only auscultation. Something else has got to be in your note. And I will put forth to you, extremities is the next easiest thing. No cyanosis, clubbering, or edema. Or something to that effect. Well, you know what? As the doctor, that doesn't make sense because extremities is not part of the heart exam to me as the doctor. Well, you got to get over yourself because guess what? To the world of the coders it is. And now your chart could be audited or reviewed. So from now on, the extremities is part of the heart exam and you deal with it. Or guess what? You don't want to put extremities? Little Jimmy's coming in for an earache. Okay, hold still, little Jimmy. Let me palpate your abdominal aorta. Nope. Femoral artery, little Jimmy? Nope. I'm going to palpate your heart? No, I don't think so. I'm going to check a pedal pulse? Maybe I will, but maybe I don't have time. Maybe I don't want to check a pedal pulse on every single person that comes in. How about the carotid arteries for little Jimmy? Or maybe I'm checking little Jimmy's pedal pulse. No, auscultate the heart and check the legs. I think that's easy for you. The point is, you can do whatever you want in your exam. Once again, I'll make the point, but you've got to have the minimum requirements from the reviewers in your note for it to be compliant with rules of CMS. Okay, let's look at respirations for a minute. Now you're checking their lungs, and you're going to auscultate the lungs. Clear to auscultation bilaterally. Okay, or no wheezing, rales or rhonchi, or bronchial breath sounds. That's a lot of information, isn't it? One problem. It's only one bullet. That's the problem. So you got to give another bullet, and I will tell you that probably the next easiest bullet is the effort. You could say all that plus no distress. That's easy. It's a lot easier than trying to percuss the lungs or palpate the lungs. So pick the easy things. And then now you're going to say, you know what, that's 6. But you know what, I'm a doctor. I like to check the belly. Well, I do too. Me too. So you can check the belly. But that means it's 7 organ systems. Who cares? Because now your code is going to be generated by the complexity of medical decision making. So now we're not worried about the EMR system racking up more organ systems and yet more bullets. So you're not going to be accused of trying to just do these great big fat comprehensive exams to drive up costs or something like that for your services. No, do the exam you think is ethical, but let the coding be generated by the MDM. Now, if you're going to do an abdominal exam, it does give you let me give you a little something on that. Remember, since medical school and residency, you've always, for the abdominal exam, the GI exam, you've always said soft, non-distended, non-tender, plus bowel sounds, no mass. It's a lot of information, isn't it? It always feels that way. But to the world of the coders, that's only one bullet. It's like, oh man, really? Yep. So the next easiest bullet is no hepatosplenomegaly. So now your abdominal exam, soft, non-distended, non-tender plus bowel sounds, you could say no mass, no hepatosplenomegaly. Boom, done. 2 bullets. And you can put that in there if you want. If you're doing the other 6, you don't. If you can do 7 organ systems, no problem. You can do 10 organ systems, no problem. The code is going to be generated anyway by the MDM. It's easier to do the examination of the belly plus no hepatosplenomegaly. It's easier than, like especially with children, you're not checking for hernias or doing an occult hemoccult test on people or checking anus, perineum, or rectum. Again, I'm advising you to pick the easiest ones that you can get in the habit of so that when you're doing the exams on people all the time, you know that when you document your work, the documentation reflects what you do all the time. And if you feel the need to do more or change some of the bullets, that's fine too. But just make sure the required bullets are there to justify the detailed exam that you, or in the detailed exam, the detailed history, and the detailed complexity of medical decision making. Now, a fine point. Going by the rules, if it's a new patient, new to your practice, all three components must be in the note. In other words, if it's a brand new patient, the MDM must be met, the history must be in the note and meeting the criteria, as well as the physical exam. However, if it is an established patient, technically it is true that only two of these three components are necessary in the note. In other words, MDM, we're saying, has to be in the note, and either the history or the physical. So you're going to say, hey, wait a minute. Are you telling me that if it's an established patient and they come in with MDM and I can just do the history, I don't need to do an exam? Technically, yes. But ethically, we're saying no. In our course, we're teaching everybody to have a history and a physical and an MDM in your note, because the notes are just going to be better and more solid. But if for some reason somebody comes in and has something going on and you don't have time to do an entire complete physical exam, but you've taken all the history and the ROS, let's say they're coming in with vaginal discharge and they have to catch a ride or something, and you need to do that type of an exam, go ahead and do the female exam. You can hold off on all this. Would your note still hold water? Yes, it would, because technically only two of these three components have to be met. And if you have all your history bullets and you have your MDM, the physical doesn't have to have this. But we are teaching that despite that little technicality, for this entire course, for all the established patients coming in and all the the case examples, we are going to take the opinion, the position, the most ethical position we can, that all of the patients will have MDM, history, and physical met. Okay? So that's an overview of how to use the form. Now, we haven't yet gotten into the rules, but I wanted to spend a good amount of time so that you're comfortable with the documentation requirements as well as the MDM requirements. So we have gone over history and physical, review of system, past medical, family, social history requirements in the note, as well as the physical exam requirements in the note, as well as the actual organ systems in the note, as well as the actual bullets per organ system in the note. And we've gone over big things like chief complaint and medical necessity and how important that is reflecting in all this. So, saying it again, a new patient visit requires you to complete and document all three components of the code if it's a new patient. An established patient requires only two of these three components, but we're going to teach it that even if it's an established patient, we're going to teach it, and we're going to show you to always try to do all three of the key components. And whether you're a primary doctor or whether you're a consultant, that very first visit to you is like a new patient visit, whether you're a primary provider or a consultant. So again, all three components of the MDM need to be met. This is where we'll stop for this, this part one. And so the next part of the Codeology course, we will start playing a coding game. It's like coding Jeopardy almost, but it's a coding game. And we will go over the risk, the data, the diagnostic management decision-making. We will look at complexity of medical decision-making and also some bonus cases to put all of this together. And we are going to go for the low fruit. We are going to hit the cases that you need to know to really boost your confidence, really boost your productivity, really boost your documentation and your compliance, and hopefully give you that really good ethical feeling that you're doing. You can be the best doctor that you can be and the most ethical doctor that you can be. So I hope you'll join us for part 2 of this. So we'll end part 1 now, and take care, and we'll see you guys next time.